Our next speaker is Dr. SUVEN BHATTACHARJEE, who will be talking on post-refractive surgery IOL power calculation.
Thank you, Dr. Nirupama, and thank you, Dr. Arup, for inviting me to this course. Most, if not all, or rather at least I was one of those who were actually pretty okay at mathematics and physics in school, but joined medicine thinking that we've probably done enough of mathematics and physics, and we see we're back from the frying pan to the fire. So I'll try to keep this simplified. And I acknowledge the contribution of Dr. Sagar Bhargav for educating me on some aspects of this. So a quick revision of biometry errors. Axial length, if you go off by 1 millimeter, you have a 3 diopter post-op refractive error. Keratometry, if you go off by 1 millimeter, it's a 1 diopter equivalent. And antechamber depth, if you're off by 1 millimeter, it's a 1.5 diopter error. Now, the problem with refractive surgery is standard keratometry methods do not apply and standard formulae both also do not apply. Simply because the parameters have been changed. If you check at the standard formulae, the corneal power is somehow it's calculated from the postoperative refraction. The corneal power is also used in prediction of the ELP. That's relevant over here. So like in any computerized system, if you put in rubbish, you're going to get rubbish. So if the data that we're going to input is not going to be of value, you don't get useful information. So post-refractive surgery, as you know, is laser vision correction, which would be all those procedures for myopia and hypermetropia, and RK. Now, the problem with keratometry in laser vision correction is they modify only the anterior surface. So the normal anterior-posterior curvature is altered. In standard keratometry, it measures only the anterior corneal curvature. The posterior curvature is actually derived or extrapolated from that. So, and this extrapolation is no longer valid after a laser correction. In radial keratotomy, what happens is anterior-posterior relationship may be maintained, but the optical zone becomes smaller, and there is a central flattening due to the corneal edema also in the post-op phase. And there is something called a radius zone error. See, what we were measuring, standard automated keratometry would measure at about 3.2 or 3 millimeters, but we in myopic elastic or PRK we have increased the optical zone to much larger place. So, and in hyperopic elastic and RK we have reduced that optical zone. So those parameters, we're not actually measuring the corneal power that we want to measure. So if you look at post RK corneal changes, if you look at this, what has happened is the central cornea is flattened, but it's a smaller area than the area that was automated keratometry would measure. In post-LASIK or PIK myopia, the changes are very different. It's a larger area which is flattened, so which is off again from what we'll be measuring. So depends upon the ablation zone. In hypermetropia, it's again very much like this thing RK, and here again the anterior curvature, the ratio is altered. So the effective lens position, although IOL calculation formula differ in the methods in estimating, in some point they use this process, the measurements that we use. So in myopic ablation, there will be reduced corneal power, and it's anteriorly incorrectly assumed to be in an anterior position. So there will be an underestimation of IOL power, and there will be a hyperopic shift. So the remedy would be in post laser vision keratometry to measure both anterior and posterior curvatures. So any device which gives you that will give you a more accurate reading of the corneal curvature, and your formula may be effective. In post RKIs, take into account whatever is the small optical zone that we have created, that needs to be accounted for. So these are the various ways. I will not go too much into detail. It's the corneal topography. There is a SIMK method, and then the Scheinflug photography, and the OCT method, which is now actually more prevalent and is being used more and more to predict, to measure the posterior corneal curvature. So this is IOL 700, which uses a total keratometry. That's something called telecentric keratometry, which measures different points. And a stress OCT is used to directly measure the posterior corneal surface and get a accurate corneal pachymetry as well. So that's proprietary over there. So in regular eyes, it doesn't really matter. Manual keratometry, autokeratometry, K from optical biometers are all equivalent. But unusual eyes like post-LASIK or PRK and keratoconus is a ratio between anterior-posterior corneal curvature that's lost, and that's where. So in that order of preference, IOL 700 anterior and the OCT-based Scheinflug devices work the accuracy works that way. Post RK, where the corneal thickness is not altered, but the central K is different from the flatter paracentral K, there are other topo, Zeiss topo, and OCD-based similar devices work, but again, we have to account for the smaller optical zone. So, post-refractive formulae overcome standard formula issues either by correcting the formulae or by the results for the issues that we have talked about already. So again, I think all of my colleagues over here have spoken of all the formulas, so we won't go into that. Now, to make all life much easier, we've got very generous, nerdy people who, like Dr. Graham Barrett and Van Kock and a lot of other people, Warren Hill, Lee Wang, Douglas Koch. So these people, they have already put it up free of cost on ASCRS and APACRS websites. All you need to do is put in the data properly from whatever devices you have, and it gives you a huge range of devices that you can use, and to the extent that you can give. So the more data that you put in, the better results that you get. So you should aim, and it calculates across various formulae, and you can go to a median range and choose your lenses. So that's about all. I would recommend a good history and counseling. We must keep the patient's expectations very grounded, because we know nothing is infallible. And there are plenty of situations where, despite all calculations, we have failed miserably. Rest is as we discussed. Thank you very much.